Thank you very much, Malik. It's my pleasure and honor, truly, to lecture in between giants of our field, Dr. Kalani and Dr. Epper. Do I have a clicker somewhere? Is this it?
That's it.
Ah, perfect. Okay, so I was told I have 20 minutes to give this talk, so we're going to be very succinct. So, as we've heard already this morning, throughout the day before, the past 10 years, we've had huge explosion of different techniques, advancements in neuromodulation. If you look at your key card right here, SI joint fusion, did we think we were going to do this 10 years ago? No. So it's my honor to talk about lumbar spinal stenosis and the minimally invasive techniques that we have available to us now. Traditionally, our role as interventional pain physicians was to essentially see the patient, diagnose the condition, maybe do one or a few epidural steroid injections, and then if the patients didn't get better, we would oftentimes send them straight to surgery. Well, now we have two techniques that are available to us to treat those patients that aren't quite ready for surgery yet, or they're too old and too sick with too many comorbidities, and they're not candidates for surgery. These are my financial disclosures. So the objectives of our talk today are to review the pertinent anatomy, the clinical presentation of lumbar spinal stenosis. We're going to look at MRI imaging. We're going to look at two procedures. One of them is called percutaneous image-guided lumbar decompression. Because this is a CME talk, I have to say that the one procedure that's available in that category is called mild. And then we're going to talk about interspinous process spacers for indirect lumbar decompression. The one that's most commonly available for us is a product called Superion by Vertiflex. We're also going to look at the MIST guidelines. Whenever these new technologies comes out, it's so important that we look and we dissect and determine the safety, number one, of these procedures, and two, the efficacy. We are very fortunate to have Dr. Tim Deer and his team of colleagues come up with these guidelines. These are experts in the field who have done these procedures, who have reviewed the literature on both of these procedures, and have come up with consensus guidelines to help us treat patients. So why even care about this? Well, the problem is that lumbar spinal canal stenosis patients are suffering. Narrowing of the spinal canal causes pain, weakness, immobility, and overall reduction of quality of life. We have 14 million symptomatic lumbar spinal canal stenosis patients in the US. In 2017 alone, 1.4 million were diagnosed, 1.5 million ESIs were performed, and greater than 175,000 decompressive surgeries were done. It's the number one reason for spine surgery in the elderly. It's the fastest growing type of lumbar spine surgery in the US. So this is a healthy spine. As you see by the cartoon there, the spinal canal is wide open. This patient is mobile, flexible, no symptoms, loving life, playing golf in the villages. In contrast to a patient here, which has a thickened ligament flavum, lateral recess stenosis is there, facet hypertrophy causes some lateral recess stenosis, foraminal stenosis as well. There could be a disc bulge. This patient cannot walk very long. This patient gets up, walks, within 5 minutes they're back sitting down. They got the classic leaned over shopping cart sign that we know about. So this is an MRI. This is actually my mom's MRI, and it was easy to get because she said, okay, sure, consent was easy. I don't know if this is going to work or not. Oh, excellent. Okay. So as we see here, there's a couple levels that we have huge amount of stenosis. At L3-4, L4-5. This right here is the thickened ligament flavum on MRI. Right here, this is a little bit thick as well. This is going to be an axial cut, and this is nice because you look at the multifactorial etiologies here. Yes, you have a big disc bulge here. Here is her tiny little canal surrounded by a huge, thick ligament flavum. Over here, you have neuroforaminal stenosis as well as lateral recess stenosis too. So moving on to piled. So ligament flavum hypertrophy causes 50 to 85% of spinal canal narrowing. So the whole concept is decompression can effectively treat lumbar spinal canal stenosis. This is the thickened ligament flavum. Here it is. The concept is that by debulking the ligament flavum, and you're only taking out a little piece of volume, but you're decompressing a very tight area. So small changes in volume can perhaps equal out huge changes in pressure in the spinal canal. So that's the premise of piled and mild. Okay. All right, this is a diagram right here. Let me pause this for a second. Let me go back. Okay, so if a picture is worth 1,000 words, I say a video is worth 1,000 pictures. So in order to really visualize this procedure, I want to show a video. This procedure is done in the contralateral oblique, which is not a view that's too familiar to us. But the reason why it's done in the contralateral oblique is because that's the best view that you can see the superior lamina and the inferior lamina, and you can really get an idea of how far those mild instruments are going, because you don't want to go too deep. Go too deep, you're into the dural sac. So this is the contralateral oblique view. I think it's going to work. Okay. The AP and lateral view is also done. The most important step in this whole process to get an epidurogram. The epidurogram is done to define a safety border that we cannot go more deeper into. So there's your epidurogram. You can see how tight that line is right there, because that ligament flavum is really big and pushing on the spinal canal right there. Okay. There's the ligament flavum. Here's the superior inferior lamina. Next, you're going to take your mild trocar. Okay, sorry. Is the video still playing? Not, it should be still playing. Oh, there it is. Okay. So here's your mild trocar coming in, just like that. And you want to land it on the inferior lamina of the area of interest. Next, you want to put on what I call a Chinese throwing star. It's actually a portal stabilizer. Then you have the depth gauge. This is important. That stops you from going too far. There's your cannula. Now you put in the bony rongeur, which you're going to make a small little laminotomy right here. It's very tiny, just taking out one chunk at a time. You happen to also be taking out ligament and flavum at the same time as you're taking out those bony pieces. You can turn it 90 degrees, take up the superior portion as well, making a nice little channel for your tissue sculptor. Now, the technique here is more of a scooping type of technique. As you press the instrument, there's a piece that slides over just like that. We have a delay. There it is. And you take a piece of the ligament there. And you're doing this on a live fluoroscopic image. So you do get a lot of fluoro exposure during this procedure. So yeah, you're just debulking the posterior fibers. The best part, do another epidurogram, boom, right away. Look at that. More flow, superior, inferior. That line, which was small before, is thickened right before your eyes. And you close with Steri-Strips, Band-Aid. All right. Okay. Let's see if this works. Ooh. Okay. So these are just some fluoro shots showing what this looks like under the fluoroscopic images. So there's your epidurogram right there. There's your thin line. Here's your tissue sculptor coming in. Going to scoop up some of those posterior fibers. And then this is post-mild. You can see that the line is a little thick. And if this was under live, you would see that you would have more flow superior inferiorly. Okay. This is just a cadaver sagittal cut looking at the ligament and flavum right there. You can see that the laminotomy opens up the trajectory there for your tissue sculptor. And the ligament becomes decompressed. Again, you're really shooting for those posterior fibers. Your epidurogram is going to be very ventral. You actually never have to go to that ventral line because you're decompressing these posterior fibers. So there's a huge safety factor there. So let's talk about the MIST guidelines. The MIST committee said that minimally invasive spine treatment, such as piled, warrants level 1 evidence. Its grade A, strongest recommendation grade, was given to them. It warrants level 1, strongest evidence. And the consensus in this committee was strong at greater than 80%. And their recommendations were that lumbar spinal canal stenosis should be confirmed with a combination of a good physical examination history taking, as well as advanced imaging. Those two both have to come together. It's recommended that clinicians who do this procedure look at their own MRIs. Oftentimes, radiologists will comment upon ligament inflavum thickening, but sometimes they don't. So you've got to kind of look at it with your own eyes and determine for yourself. You have to evaluate for spinal stability. PILD is indicated for patients with grade 2 spondylolisthesis. This is important because the interspinous process spacers are not indicated for anything more than grade 1. So we'll review that as well. And then you have to look for the ligament. If the ligament is greater than 2.5 millimeters and you really think that that's the major etiology here and not some lateral recess stenosis, then mild is a reasonable choice. Some more about the MIST guidelines. Even though the mild device is designed to debulk centrally and take out that ligament inflavum, the MIDAS Encore study did show that patients who had foraminal stenosis, facet hypertrophy, bulging disc, those were positive predictors for success. So this goes back to the idea, perhaps, that if you take out that posterior portion of the ligament, you're really decompressing the spinal canal, and that patients with all those other things, they can do better, and that's what their study data actually showed. Long-term data. So just to review quickly the MIDAS Encore study, this was a pretty pivotal study for this device. It was actually a study that was funded by Medicare. It was a prospective multi-center study, 26 sites, randomized, controlled, 302 patients involved, and it was PILD versus epidural steroid injections. Study visits were done at baseline, 6 months, 1 year, 2 year. Comparative data was done through 1 year, and then the PILD group had comparative data through 2 years. The outcomes were a reduction in the Oswestry Disability Index and the numeric pain rating scale. The study population was patients who had thickened ligament inflavum greater than 2.5 millimeters, 65 years or older, ODIs greater than 31, and a pain scale greater than 5. No surgery at that treatment level. And the spondylolisthesis was studied no more than grade 2. So they have grade 3 or 4, those patients probably need surgery. So the outcomes were